Hi everyone, my name's Mattie. I use pronouns they and them. I'm a PhD candidate here at the University of Victoria, and I live and work on Lekwungen territories here on the lands of the Songhees, Esquimalt, and Wasanich nations. Work for the project that I'm talking about today also occurred on the lands of the Squamish, Tsleil-Waututh, and Musqueam territories as well. Today I'm sharing about early, super fresh findings from a community consultation that actually happened only a few weeks ago, related to trauma-related mental health supports for trans and gender diverse young people. I also want to acknowledge that this work is done in collaboration with a lot of other people, including Loris Height, Owen Ballandine, Darren Ho, and my group of community advisors who chose to not have their names connected with their work on this project. Let's see if I can move the slides. I can. So community partners for this project included the Community-Based Research Center and the Urban Native Youth Association, and it's supported by funding from various sources here. So a bit of background information on the project. Many trans and gender diverse people find that mental health services don't feel helpful or safe or accessible. When they do access mental health care, often there's barriers to accessing care, or care is unhelpful, and it can even be re-traumatizing. There's an identified need for care, but there isn't a lot of research or literature on how we can make care better. There's a lot of information about how there needs to be research on this, but not exactly how we want to improve this. And so this is what started this project here. This project is a community-based research project to make trauma-related mental health support safer and more accessible for trans and gender diverse people. For this portion of the project, looking at young people, so people ages 19 to 30 with experience accessing or wanting to access trauma-related mental health care in southwestern BC. This project is hoping that we can improve mental health services that provides trauma-related mental health care for these communities by identifying areas for improvement, barriers to access, and directions for future research that are centered on community needs and priorities. The name of this project, Transforming Supports, actually came from a group of community advisors that wanted something that acknowledged that we really want to change things and we want to see a different form of support that's being built by community priorities. So the goals of this project are to understand what people's experiences are like in care, identify the ways that we're finding support for our mental health and what feels helpful and what doesn't, identify recommendations for improving care, and then communicate these findings to healthcare providers and organizations and policymakers so that we can start to make a difference. Flipping the notes here. So the community consultations that occurred a few weeks ago in March were created in collaboration with the Community Advisory Committee and then community partners, including Community-Based Research Center and the Urban Native Youth Association. For recruitment, we did online poster recruitment through listservs and then also in community organizations, mental health services, campus pride groups, and then also other local locations in and around the Vancouver area. We're inviting trans and gender diverse young people ages 19 to 30 with experience accessing trauma-related care. The location of the event occurred at the Urban Native Youth Association in Vancouver, which is on the land of the Squamish, Tsleil-Waututh, and Musqueam nations. This happened earlier this month, and there was two in-person events that were 2 hours each of facilitated discussion and written conversation. So me and my co-facilitator created some activity groups where we had discussion and folks would write their ideas on large pieces of paper. And then we looked at all that and kind of put it together as, what are folks saying about these topics? So our focus was looking at service experiences, so what services had been accessed, what the experiences were like, what was needed or wanted, the experience of safety when accessing services, what was a safe or an unsafe experience, access and change, so looking at barriers, hopes for improvement, what would helpful care look like, and then priorities for research, approaches and how we want to see things researched, and who needs to hear these findings. So for the purpose of this presentation, I'm going to talk about the service experiences and the priorities for research part of this, and hopefully get to share more information down the road. So the participants, we had 17 people participate, 15 people attended in person across the 2 days, and 2 completed online conversations due to accessibility. We had people from various locations in and around Vancouver, including Burnaby, Surrey, Victoria. Somebody trekked all the way over there for it. Richmond, New West, and the majority from Vancouver. The majority of participants had experience accessing trauma-related supports and wanting to access supports, but couldn't get it because there was barriers. We recruited for ages 19 to 30, but participants showed up that were between the ages of 17 and 33, so there's a little bit wider of an age range. But because it was a community event, when people showed up at the event, we said, welcome, you can come on in. There was a variety of experiences in the room. We asked folks to describe how they described their gender when they registered and checked in. So 41% of folks used the word trans to describe their gender. This included trans man, trans masc, trans woman, and just the word trans. 47% of folks described their gender as non-binary, and 29% described their gender as two-spirit. Folks also use the words agender, gender fluid, or male or female to describe their gender experience. We also asked folks to share what other experiences in their life that they felt was important to position their experience and what they were sharing in their perspectives. Folks shared things about their sexuality and sexual orientation, including that they were queer, indigiqueer, bisexual, or polyamorous. People shared things about their race and ethnicity, including that they were Indigenous, Filipinx, settler, Vietnamese, Peruvian, Taiwanese, and mixed race. People also shared things specifically about their mental health experiences, so using words like mentally ill, bipolar, having PTSD, or experience with eating disorders. And people also shared things that they were neurodivergent, that they were physically able or disabled, that they had experience with chronic illness, that they were working class or were a sex worker, they were low income or spiritual. So people shared particular things about themselves that they thought was important for their perspectives when we were asking their opinions and perspectives on these things. So when we asked folks, what kinds of services have you accessed or attended, people named specific things and then also talked about services more broadly, kind of broken it into categories of things that people talked about. There was a lot of experience with health authorities, so things like hospitals or clinics or GPs, psychiatric services, phone lines and crisis lines, addiction services, school supports, individual therapy, Indigenous supports, peer support, or centers with multiple services. People said that they needed or wanted things like trauma therapy, culturally competent therapy or supports, crisis support when they needed it, Indigenous specific support, things that were trans aware or trans educated, medication support, specialists on things that were affordable. They wanted assessments, consistent support, so seeing the same person more than once. Being able to get a service when you needed it, so not having wait lists, and then being able to refer themselves to services when they needed something instead of having to go through a doctor or another professional to get something that they know they needed or wanted. So some of the barriers that people mentioned that they experienced were that the support just didn't exist. When they went to look for it, it didn't exist. So providers weren't a good fit. There was a lack of gender affirming care, lack of culturally competent care, lack of trans and gender diverse providers, lack of QT BIPOC providers, and a lack of affordable options. Affordability and financial barriers was a huge theme throughout the conversation. People shared they had experiences with transphobia and anti-trans bias when they were accessing mental health care. So a lack of knowledge about trans identities and needs, having to explain things like hormones to healthcare providers, not being able to trust their providers, having information shared without their permission, running into stigma, and then this idea of a lack of safety. Things didn't feel safe when they went to them. Many people shared about experiences of racism as a barrier, so racist assumptions about what would be helpful or what wouldn't be helpful, discrimination, lack of understanding of Indigenous cultures, and a lack of understanding of Two-Spirit and Indigiqueer identities. Other barriers included age limitations. So being the age that we were inviting people in, it's right on the cusp of when people age out of youth services and into adult services. And so really running into this challenge of what service can I get? And gendered requirements for services, and finding the Find a Counselor tools very confusing. And again, wait lists and no availability. I'm gonna go quickly because I got my 5-minute warning. So the research priorities that people talked about, we asked them, well, what do you want to see researched about this? These are your experiences. What questions do you have? So this idea of like, well, what does trauma actually mean for trans and gender diverse people? Is there a different definition there? Is there something, are there things that are traumatic for trans and gender diverse people that doesn't fit in the definition of trauma right now? Particularly for trans and gender diverse children. What can be a traumatic childhood experience? People were really curious about provider education and training. So what defines trans competency? How are people trained? How many people are actually knowledgeable in this area? The idea of co-occurring needs, so commonality of things like eating disorders or autism and neurodivergence in our communities, and is there research about this? And then also understanding diverse experiences and contexts, so the different experiences between urban and rural settings, ableism and mental health care, and integrating truth and reconciliation into service. We asked how we should research these topics, so what kinds of mediums or approaches do people want to see? There was a lot of talk about this idea of seeing the whole person, seeing humanity. Is there ways of sharing people's stories? People suggested things like documentaries, being able to show the actual experiences people are having in this and show this to service providers. Things that didn't feel academic or non-written forms, things like being able to text your ideas, have verbal conversations, be able to have a phone call about something. And also the idea of research on providers, so shifting the attention from trans and gender diverse community to researching the people that are offering support. So doing surveys for doctors and mental health providers on like how much do they know, how do they need to do things differently. There was a large conversation about how research needs to be community driven, so things written by the community, process led by community. Academics should be in service to community, and lived experience should define the goals of the research. The priorities for change that folks identified were that there needs to be a change in the process for accessing support. Again, this idea of self-referral, if folks know what they need, they should be able to get that. Believing people when they say they need help. So when someone comes to a service and says they need help, actually being able to get that service instead of being turned away saying you're not in crisis enough or this service isn't for you. Continuing education for practitioners, culturally appropriate service, value of Indigenous knowledges, affordable support, again, that financial barrier, no gender assumptions in care, and then trans competent care. Participants identified that people that need to hear this information are healthcare practitioners and professionals, people like mental health providers, hospitals, clinics, and paramedics, government and policymakers, so things like health authority and the criminal justice system, education systems, including post-secondary and high school as well as education within training programs like medical and nursing schools and counseling schools. And then community organizations, so mental health organizations and queer and LGBTQ organizations. People identified that even though there's some things that feel okay, there's a lot of improvement that can be done in queer orgs, and then crisis lines and counseling groups as well. I'm probably on my very last minute, so I'm on my last slide, yay. So the next steps for this project is there's gonna be a series of individual interviews that is kind of building on the same topic of this project, and then a knowledge sharing event, taking the information from this presentation, and then also the things that I haven't been able to talk about today, sharing this back to the participants and other community members, and creating community reports that can be started to share with some of the people that the participants identified as needing to hear this. And the main goal coming out of this is that the questions that folks identified are things that can guide future projects. So building on the priorities people are identifying, can we do some of the research that people are saying needs to happen, and how can we continue to engage the community in this and build community partnerships. Thank you very much.
I am Roz. I am here today to talk about sex and gender in digital health systems. My name is Roz Queen, she, they. I'm presenting on behalf of my team. Yeah, so let's just get into it because there's a lot to cover. So just a little table of context. First, we're going to talk about the current landscape. Then we're going to talk about the proposed solution. And then finally, some successes and problems, because no solution is perfect and there's going to be problems. So first, the current landscape. So I just wanted to talk a little bit about what digital health systems mean, because it encompasses a lot of different stuff. So it can be stuff like electronic health records for patients. It can be if you telehealth, if you ever see a provider through Zoom or anything like that. It can be vaccination passports and stuff like that. And there's a lot of varieties. They vary a lot by hospital, clinic, health region, country, and stuff like that. And within these systems, there's no systemic standardized way to collect gender and sex data. If it is, it's in a very early stage, and sometimes it's only at like specialized health clinics, like they talked about like gender affirming surgical cares and stuff like that. So that's what digital health system means. It encompasses a lot of stuff. So basically, those sex and gender data, this often comes from outside of digital health systems into it. So it's stuff on like your passport, your driver's license, stuff like that. And I say sex and gender because they're very much conflated. They're different things, but in the current system, they're very much conflated. So I just kind of put them together. So this enters the digital health system. And then in the digital health system, it has two main uses. So clinical uses and administrative uses. So clinical uses are basically anything for patient care. So determining reference ranges for blood tests, giving diagnosis, shielding for x-rays, preventive screenings, which is a big one, cancer for certain organs, prostate, cervical, etc. And then administrative uses. So billing and insurance, patient identification. Often when you enter a healthcare thing, they'll ask for your name and date of birth. And sometimes if they need another point of data, they'll use your sex. Room assignments, public health surveillance, etc. There's a bunch of different uses. These are like the two big categories, and there is overlap. Like the room assignment, if you get admitted to a hospital, that will overlap with clinical services and etc. So this causes a lot of problems. Having this single point of data, well, sometimes multiple points, but sometimes just one single data, and using this for a bunch of different reasons, it causes a lot of problems. So one, assumptions. It makes assumptions based on like, what does the data say? And what does that say about you currently? So that could be like what's on your birth certificate, which was, like 30, 40, 50 years ago. Or it can be based on what's on your identification. Makes a bunch of assumptions about you, your body, what you want. Inappropriate healthcare related to assumptions. Straight up harmful healthcare that, like Mattie talked about, can cause harm to people and actively hurt them. Billing problem, so some procedures can only be billed in a very specific way. So like pregnancy for ultrasounds, sometimes that claim will get rejected. This is less a problem in Canada, but it can be a big problem for private insurers, the United States, other countries that are privatized healthcare. Data invisibility, so we really just don't know a lot of data about trans and non-binary people and two-sphere people because it's not really collected. And if it is, it's done in a way that's not very clear sometimes. And then healthcare avoidance. A lot of people avoid healthcare until it's an emergency, and they present in an emergency room with very intense symptoms and stuff like that. And that just that's bad. I'm gonna go out on a limb and say that's bad. All right, so proposed solution. So basically, let's think of an example. So you have a patient that comes into the hospital. And let's say they come in with pelvic pain and they need an x-ray and a blood test to try and figure out why they're having pelvic pain. So what do you really need to know about this patient? A, you need to know what organs they have. For the x-ray, you need to know for like screening and stuff, shielding. So you don't want x-ray, which is radiation, going into particular parts, especially stuff like egg cells or sperm cells, because that can really mess up your DNA. So you need to know that. And then for the blood test, you need to know what hormones they have. So figuring out what the reference ranges are all, what falls outside of those reference ranges, and that can be like a flag to the healthcare providers of like, oh, this is not right. It's too low, it's too high, it's something. So these two is what we would call anatomic inventories or anatomic inventories. So those are the proposed solution is basically do this. So let's talk about the organ inventory. So it lists what organs the patient actually has. And I know that sounds very obvious and very simple, but it is not currently being done that way. And it's a very straightforward solution that isn't being done. And it's not being done for a lot of reasons. I'll get into that in a bit. But so this could be stuff like reproductive organs, ovaries, testes, prostates, etc. Non-reproductive organs, kidneys, lungs, breast/chest, etc. So it would list off all of these different things. And it can list if a patient has both or just one. So that's called unilateral or bilateral chemistry. So with kidneys, for example, some people only have one kidney, or some people only have one functioning kidney, or some people have two kidneys, but one is introduced from an external source, which means you have to do stuff like immunocompromised drugs, and so it doesn't get rejected and stuff like that. So that kind of information is really helpful to have in healthcare settings to know what's actually going on. Same with reproductive organs. Sometimes someone only has one testicle due to trauma, testicular cancer, etc. So this could be done with a presence and absence model, which is an ICD-11 code. And I think it goes back to like ICD-7 or something, but it's used in a similar way. It's just not used in this particular way. So next we're going to talk about hormonal inventories. So it lists what hormones are present within a patient body and at what levels. So this can be baseline levels or goal levels. So with hormone replacement therapy, it takes a while for that to build up in your system. So it can be related to what are you trying to achieve, and it can kind of include both of those things. And once again, these can be gender-related hormones, testosterone, estrogens. Those are the big two everyone knows about, but there's a bunch of other ones, such as this one, which is very helpful to detect menopause and determine if someone is going through menopause or not, and a bunch of other hormones. It can also relate it to non-gender hormones. So these two are really important for liver functioning and determining how well the liver is functioning. And the liver has about 500 functions in the body. It is very important for very many things. So knowing this type of stuff is very important. And then GH, which is used for pituitary gland function, and tumors, which once again, tumors cancel bad times. And so this could also include if these hormones are produced in the body or introduced from an external source, such as prescriptions. This is just like more data that can be helpful for different stuff. And the fancy scientific way of saying that is androgen, estrogen being from without. And that can be important for if you're getting prescribed, it might interfere with a different prescribed thing. Or if you have the organs that produce a certain hormone, but you're suppressing them in your body, all that data could be helpful for kind of stuff. So that's kind of the proposed solution. And now I'll talk about some successes and problems of this. So first, successes. I like to start off with successes because, you know, good news first, all that good stuff. So biggest and largest is improves patients' healthcare experience. So it helps support patient-centered individualized care. It helps personalize interactions between you and your healthcare provider, because a lot of healthcare is based in interpersonal relationships and communication, and limits inappropriate care. So for limits inappropriate care, that can be stuff like if you get a screening for testicular cancer as like a preventative screening for cancer and just general functioning, but you don't have testicles, that's kind of a pointless thing. Like, you cannot test them, even if I had them, like you can't do it. And on the other side, if you get the screening and you have testicles, but you don't get the screening, that means you might have not early detection of stuff. So it's inappropriate, it's a waste of time, and it doesn't promote preventive screening. So create rich data sets for secondary uses. So secondary uses are kind of all these things here. And like I said, with the data invisibility, we do not really have data about these things. And this data can be really helpful for research, quality improvement, best practices. Best practices are like, oh, this patient has this symptoms and they have these organs. What is the best way to treat them? Which are a very standardized way of promoting healthcare. So it's similar in all the different things. Policy and legislation, like Mattie talked about, to like, you can take this information and give it to the people that are making the policy and legislation. And this can both be government bodies and professional bodies like Doctors of BC. And hopefully with all of this, improving healthcare for future generations, so they do not have to experience the problems that are caused by the current system. And finally, eliminate assumptions. This goes with improving healthcare, but healthcare is based on what the patient actually has and what their current body is, not what they were born with last year, not what they had last year. It's what is going on right now as they present in the clinic and what they need moving forward. It doesn't make a bunch of assumptions based on different points of data. So these are just some successes. There's other successes such as saving in healthcare spending, which I talked about with like the testicular cancer thing. It's a waste of time if you don't have them. And improving preventative care. So that's it. And then for problems, every solution has problems. There's always going to be problems, especially in the early days. So first of all, implementation. Leo pointed this out to me as he was giving me feedback on this. So resistance of change. Change is scary, change is hard, change is expensive. Some people straight up don't want to change. They're like, oh, the current system works fine for what I'm doing. I've been doing this for 40 years. Why do we need to change? So that's a big thing that needs to be overcome. And the other one is organizational readiness. So say your organization really likes anatomic inventories. They think it's a great idea. It would improve all these things. They want to do it. Are they actually ready to do this? Or do they have the resources to do this? Is their staff ready to do this? So this is especially for communities and care providers that are under great strain or have limited resources. So for example, First Nations in Canada are still fighting for clean drinking water. They may not be able to have the resources to dedicate to doing an update. So next, privacy. This is a big concern in healthcare, as always, especially stuff related to sex and gender. So it can potentially out patients. So if you're a man that has a cervix, having that in your healthcare record can out you to people. And then sharing of data, so access to data. So say that you're out to your healthcare provider, like your primary healthcare provider, and they're really cool, but they have to send a referral to something. Do they have to include all the data, or do they have to include only what relevant? And the person getting the referral, can they access the full anatomic inventory, or only like, oh, this person needs an x-ray for this part. These are the important parts. Always kind of a concern. And then maintenance. So maintenance is important. Healthcare is very complex. And the sex and gender data now, it's very simple. It has 1 point of data, 2 points of data, and it treats those as unchanging and permanent. And that is really, really easy to maintain going forward into the future. But inventories are much more complicated, and it's very important to ensure that they're up to date and accurate. And the question of accuracy can be kind of difficult, because is that the physician accurate? Is it the patient accurate? How does it kind of do this? And there's going to be IT problems and bug fixes that need to be maintained going into the future. And this is not just to ensure that the data is entered correctly, stuff like that, but it's being used correctly within healthcare. Because if we create all this data, we need to use it to improve healthcare. We can't just collect data because we want to collect data, you know? And there's a bunch of other problems, such as legal considerations. Is this going to be mandatory? Do you need to share it? Stuff like that. And what were the other ones? Interoperability. So that's like sharing between different health departments. Like, can you share this data with other people, etc. So next steps. So first of all, community consultation. That's kind of what this presentation is about, informing the community and letting them know, not only for the trans and non-binary community, but like healthcare providers, nurses, checking in with professional bodies, all those kind of things, because there's a lot of stakeholders that are involved in those. Next, developing use cases. This is kind of what I talked about with best practice. So developing a use case of like, this patient comes in with this problem. How do we deal with this? How does anatomic inventories deal with it? Prototypes and mockups. So these are very high level versions of anatomic inventories that do not have all the functions involved in them, but it's like, this is what it could look like on a screen, or this is what it looks like in a clinical environment. Policy creation, legislation. So that could be hospital-wide, that could be health region-wide, that could be government-wide. Pilot testing. So a pilot test is a very small scale test. So it's like in one specific clinic or one specific hospital, or sometimes one department of a hospital, such as radiology, which is for like x-rays and stuff like that. So that can be a very small scale test to be like, does this actually work, before you expand it out. And once you expand it out, that would be wide implementation. So throughout a hospital, throughout a health region, Ideally, throughout all of Canada would be perfect. And then, okay. So this is kind of like a circle. Once it is widely implemented, going back to the community and like, does this meet your needs? Are there any problems with this? Does it support clinical care for doctors and nurses and stuff like that? And it doesn't have to be necessarily a linear thing. Like if you got to pilot test and you're like, oh, actually we need to go back to use cases because like in our pilot test, a use case came up that we didn't think about. Or once policy is created, going back to the community and see it source of need. So it's like a circle that goes around and it can also like jump around. So finally, just going to talk about some conclusions because I talked about a lot of stuff and there's a lot of stuff going on. I also made this person specifically to look like me. So current digital health systems have many shortcomings. This results in many negative aspects for patients, providers, and systems. Anatomic inventories are a proposed solution to alleviate, limit, or fully eliminate the negative aspects. They capture rich data about what organs and hormones are currently present within a patient's bodies. And where there are some challenges with implementation and the use of anatomic inventories, there are many benefits to be gained. All right, so thank you so much for your time and attention. I really appreciate it. Oh, one time. So this is my contact information. I will say I am getting out of research. So if you email me, I might send you on to my team members, such as Kayla and Courtney, or I can answer short questions. We have 2 websites. One, the URL is pretty nice. Oh, you can't see it up though because of the caption. It's justsohealth@uvic.ca. Or there's another one that the URL is a little longer. So if you just Google Canada Health Infoway Sex and Gender, that's like what we'll host it through. So that's it. I look forward to your questions.